and we will begin the presentation. As you recall, it's on falls today, and we all seem to be up and everything's running. So one more minute and we'll begin.
Yes.
And we're ready to begin. So as I said, today we're covering falls. Very, very simple indicator. Not a lot happening in this area, even though it's such a critical indicator for the ministry. And of course for issues of falls and fractures and the potential for hospitalization and obviously for decline in health status in general. So we're looking at falls. Once again, we're going to go through this each and every time. Remember, in the 35 QIs, there are two types of indicators, those that are called the prevalence indicators and those called incident. Incident indicators are going to look at improvement and decline. So we can see that we've got 12 prevalence indicators. We have 9 of the improvement indicators, and we have 14 of the decline indicators altogether. Please remember, there'll be nobody included in the study who has a length of stay of less than 93 days. So that obviously means that anyone with the initial 14-day assessment is not part of the report for the CIHI reporting. So CIHI reports only use assessments that have an ARD date of 93 days after the admission date. And if there's multiple assessments done in a quarter, then only the last assessment in each quarter is used for reporting purposes. Okay, that doesn't mean they're not of some value to yourselves, but for reporting purposes, it's only the last assessment. Now that's where we're only using one assessment, or what's called a prevalence indicator. When we look at the incidence indicators, and we have to look back to a prior assessment to find out if someone's functional status has improved or to find out if someone's functional status has declined, there's one more condition with the incident indicators, and that is the last assessment that we're looking back at has to be at least 45 days ago. So no more than 45 days between the assessments and no more than 165 days ago, which the 165 is probably not a problem at all, but we'll need to be careful when we're moving ARD dates around in order to balance our workloads, that we're not moving them within a 45 days of the next assessment. Okay, so now that we've looked at that, once again I'll cover population risk adjustment on the last day, and we'll look at one example of what a population risk adjustment is and how it affects your scores. But the example we've been using all along is that if 2 sites had 10% fall rate, you might say they're equal in performance on that indicator. However, if one home had very few people with dementia and medications and younger, you would expect that home to have less falls. And if the other home had people with more dementia, medications, and were older, you would expect them to have more falls. So the population risk adjustment simply adjusts your score to consider the risk or the difficulty of care within those residents within your home and try to equalize the two homes in that way. So we're talked about the rolling 4 quarters, always 12 months of data in a CIHI report. Always 12 months of data is involved in the report. Now you can see with the prevalence indicators, and then when we look at the incidence indicators, we're bringing in one more quarter, a 5th quarter here. It's not included in the report calculation. However, we need it so that this quarter can look back at something to see if there was improvement or look back to see if there's decline. So that fifth quarter that will be included will simply utilize that for reflective purposes. Now today we're looking at falls. We've already covered the ulcers. We've already covered daily physical restraints and taking antipsychotics without a diagnosis. So we have falls, and we can see fall is one of the 12 prevalence indicators. So we're only using one assessment. We're not looking back to a prior assessment in the prior quarter. You can see we haven't looked at any of the improvement indicators as of yet, the 9, and we've only looked at the one decline indicator so far, and that has to do with the decline or worsened stage 2 to 4 pressure ulcers. So those topics have all been covered. So when we look at falls, we can see that falls, from a modeling point of view, covers a large number of possible causes or risk factors for an individual. And MDS does not cover all of these in the RAPS and the CAPS. You can see that there are obviously mental health issues that would put a person at higher risk for falls. Of course, physical weakness and frailty would put a person at higher risk. Vision defects, musculoskeletal problems such as arthritis, neural, epilepsy, stroke, Parkinson's disease, all put a person at higher risk. People with heart problems, environmental issues within the setting that they're in, and of course other factors, use stick, etc., or if they have had previous falls. So all of these are considered to be a numerous number of risk indicators, but we're going to see that the RAPS, which is supposed to show us risk of falls, is not a very powerful instrument, and it tends to overestimate the number of falls. And then we look at what are the effects of fall, and we can see that there's a large number of possible outcomes from someone falling. Physical effects, immobility, mental health effects, social effects for an individual. Okay, so all of these have to do with an individual who's at risk of falls. They'll tend to walk less, so they'll be less socially engaged. They might become depressed by their lack of confidence in their ability to locomote, and so forth and so forth. And not moving around to avoid falls also increases the risk of immobility and other factors. So once again, we're going to look at falls, and you can see it is on my list here of Health Quality Ontario benchmarks. So Health Quality Ontario is looking at a 9% rate as the gold standard. And we can see that in the last reporting period for Ontario, the average was 15% or 15.5%. So we're still quite a ways away from that 9% goal that we're hoping to achieve. Oh, I want to go back up there for a moment. Once again as well, this column right here in your report shows you those quality indicators that nursing care can have an impact on. And as I said before, this comes from Carol Esterbrook et al., who've done a study working with experts across Canada as to what are the top 13 areas that nursing can have an impact on. Notice that falls ranks number 10 out of 13. So it's not as easily altered or dealt with through nursing care as, say, ulcers or restraints. As we see, ulcers are the number 1. Pain is the second highest one that we can affect. And this one's all the way down at the 10th highest. But it's still one of the items that we can have an impact on from a nursing perspective. If we, just a couple of definitions from CIHI, and here there was a question on the e-query that asked about a preventative fall, and CIHI notes here that a preventative fall is not considered a fall. Now, the only reason why that might be interesting was when MDS was first initiated, even preventative falls were considered falls. So now you can see they're clearly saying prevented falls are not falls. Okay. Another question from CIHI, and this person wanted to know what was the rationale to using the 30 days prior to the ARD. So if you fell within that 30 days, including the ARD, of course, and the 29 days prior to the assessment reference date. And they're saying if the quarterly Q, and their concern here is that you're going to double count. So if the quarterly QI report use fell in the past 31 to 180 days, the same fall could be contributed to more than one quarterly report. And so the concern for CIHI was to not pick up on things that happen in more than one quarter when it's the same fall. So the 31 to 180 day indicator is not used. We're going to see that we do use it when we're looking at the risk indicators. So falls 31 to 180 days ago are going to be a risk indicator in the RAPS, but they're not used as part of the quality. Okay? So there are no exclusions other than the ones we mentioned when we came in. There's general exclusions, so there's no exclusion factors here at all. And you know, that might be a little strange because one would think that we would exclude people in a coma or people with quadriplegia or people who couldn't fall, and I'm not completely sure of all the logic. However, here we're indicating that there are no other exclusion factors. The trigger that sets this quality indicator is just one item on your MDS form. Section J4 accidents, item A, fell in the past 30 days. Okay, and so I've blown it up here on the side just to make it clear. So it's just simply if you answered yes to that question, then you're going to trigger this particular quality indicator on your health quality reports and on your CIHI and ministry reports. We then have the calculation, which I've already stated. On the current assessment, if the MDS item fell in the past 30 days equals yes, then it's triggered. So very, very, very simple. Now this is the risk indicator. And you can see in order to calculate the RAPS, the risk for this item, and it's just either triggered or not triggered. So it's just 0 or 1, not triggered or triggered is what the outcome is. The items that are going to be involved in the risk calculation have to do with falls in 30 days. Sorry, let me go back. Falls in 30 days. Sorry. Falls in 30 days. Wandering is another risk indicator. And we're only using the A side of the item. Does the person wander from E4? Dizziness is also a risk indicator. That comes from J1F. If trunk restraints are being used, they're saying that's an indicator. And then the receipt of the anti-anxiety or antidepressant medications are also risk factors. And you can see for those, it's the number of days that they've received those indicators. So if you look at the calculation, it's rather straightforward. We're going to take all of the items we mentioned, and if there was a fall in 30 days, is yes, you trigger, or 31 to 180 days, you're going to trigger, or wandering will trigger it, dizziness will trigger it, or trunk restraints will trigger it, or the medications will trigger it as well, whether it's 1 day to 7 days of the antipsychotics or the anti-anxiety medications. So either one of those. So you can see any one of these 7 different factors could trigger this item. There's no combination of items. There's no higher risk or low risk, which is really one of the major problems I find with the RAPS, is that it would be better if these indicators were measured where we can look at no risk, low risk, medium risk, high risk, and care plan level, which would be a much nicer way of looking at these and making these a more useful tool. Now the caps are supposed to make it a little more fine-grained, but then the caps, for some reason, get rid of all of the things that we would think are risk indicators. So I have no idea how the caps are a better measure than what the RAPS were in this case. You can see with the RAPS we're using wandering, dizziness, restraints, anti-anxiety, antidepressants, all factors that we know place a person at higher risk. A little bit unusual that dementia is not included here as a risk factor as well, but it's not in this particular case. But you can see here on the caps, all they're using is felon 30 days or felon 31 to 180 days, which if you fell, then it's going to show you that you're at risk of falls, I guess, which seems to be pretty obvious. Not really much of a predictor of anything very useful. But if you notice here, there are 3 outcomes. The first one is not triggered. The next one is triggered into medium risk for future falls, and then or triggered into high risk for future falls. So let's go down here and take a peek at what the high risk for future falls looks like. So if you fell in the last 30 days and you fell in the last 31 to 180 days, then you're going to be triggered at high risk. If you fell in the last 30 days but you didn't fall in the last 31 to 180 days, you're going to be considered a medium risk, else you're not considered a risk. I just happen to think it's a really, really weak predictor of risk. And the real major things that we want to know about, I would say, are the ones that we saw that were in the RAPS to begin with. So I will not look forward to us changing to caps from RAPS. Now the last thing is we've seen how it looks from a quality point of view, from a risk point of view with the RAPS, from a risk point of view with the CAPS, the clinical assessment protocols. And then we have the funding model. And this particular item, J4A, fell in 30 days, does not impact the funding model at all. So there's 105 different items that all could put you at a different funding level, but falls is not one of the items that have anything to do with funding. Now, wouldn't it have been great if they would have taken some of the preventative measures to prevent falls and then funded you for those items? And if your items are in place and you have no falls, then you're a great performer quality-wise, and you're getting paid to have that great performance. So in this case, there is no financial reward at all for homes to put in fall prevention programs, which are costly and take a great number of resources. So that's one area, if you ever get a chance to have an opinion with the Inter-I group or the Ministry of Health, start putting in payment items that reflect care when we're actually getting good outcomes, a pay-for-performance type of measurement. So that is a very brief one. Falls, not a lot happening with the falls. Again, there's an area for you to leave questions where you can send them off to me, and I will reply by email directly to you. And also, please remember that we have the RAI Users Forum, and we've already had a number of great materials put up there, and I see there are people who are logging into the rai.to forum, and there's some great questions that have been asked, and if you have an opportunity, I would love to see you log in and take a shot at answering some of those questions and maybe get some insight from the things that are there. Thank you everyone for participating. We'll see you again next week, and goodbye for today.